too, I welcome you all to this medicine CCR. So the case that we're going to present, expecting the unseen, it's a very interesting and a complex case. I mean, if you look at it, it's not your normal scenario that diagnosis was made and they lived happily ever after. It's more pragmatic. There are a lot of complexities and how we maneuvered them. So I think it will be interesting for all to see. The case will be presented by Dr. Rachita. She is the JR in the department, and the review of literature will be done by Dr. Bharti, who is the SR in the department. So let us get started.
Thank you, sir. So now we'll be starting with the case. So we have a 29-year-old female. She is resident of Meerut, herself MSc nursing student, married for the past 8 years. She is gravida 3 para 1 live 1 A1, currently pregnant at 12 weeks and 2 days of gestation, and she is right-handed. So she presented to us in the OPD on a wheelchair with fever for the past 3 days and shortness of breath for the past 2 days. Patient was apparently well 4 days back when she started having fever. It was documented 103 Fahrenheit, spiking 1 to 2 times per day, not associated with chills and rigors, and relieved on oral antipyretics. Apart from that, she also developed sudden onset and rapidly progressive shortness of breath, such that she was not able to complete sentences, and that was associated with significant orthopnea. Along with that, she also had a history of diffuse pain over the bilateral shoulder and hip region, and also she had a swelling in front of the neck. Apart from that, there was no history of sore throat, nasal discharge, cough expectoration, chest pain, palpitations, pleural edema, skin rash, oral ulcers, decrease in output, abdominal pain, jaundice, vomiting, diarrhea, headache, altered sensorium, or a focal deficit. No history of abdominal pain, discharge, or bleeding per vagina. Now talking about her background history, so she has presented to us initially in 2010 with complaints of fever, non-scarring alopecia, and small joint polyarthralgia, and she was admitted and she was diagnosed as SLE with musculoskeletal and mucocutaneous manifestations and was started on treatment, after which there was improvement in her symptoms. But after 2 years again, she presented to us with on and off fever, which was again appearing on tapering steroids, and there was also swelling in both the axilla. At that time, there was no history of rash, oral ulcer, increased arthralgia, or alopecia. And imaging was done for evaluation, which showed enlarged lymph nodes with distinct margins on both the sides of the diaphragm and mild hepatosplenomegaly. A lymph node biopsy was done, which was suggestive of Castleman disease, hyaline vascular type, and initially steroids were started, and she was diagnosed as a case of multicyclic Castleman. Further, she was being followed up in OPD where, because of persistent lymphadenopathy, she was counseled about rituximab, but it was refused due to financial constraints. Further, she had a loss to follow-up and an irregular medicine intake. Again in 2015, she presented to us with fever and small joint polyarthralgia. Repeat imaging again was done, which was suggestive of persistent lymph nodes. Again, she was advised treatment and was advised adherence to the treatment. Further, she had improvement in the symptoms and had discontinued treatment by self because of that. In 2021, again, she presented to us and advised treatment, but again had a loss to follow up till her current presentation in 2023. So now coming to her obstetric history, she is gravida 3 para 1 live 1 A1. First pregnancy was 7 years back, male child, spontaneous conception, normally delivered at 9 months without any complications, currently alive and healthy. Second pregnancy was 6 years back, and that was an unwanted accidental pregnancy, terminated medically at 6 weeks of gestation. Currently is the third pregnancy. It is a spontaneous conception and a gestation of 12 weeks and 2 days. In personal history, she's been having difficulty in sleeping for the past 1 to 2 days, when she used to experience sudden shortness of breath immediately on lying down, and that was associated with excessive daytime lethargy. Apart from that, she consumed mixed diet, normal bowel bladder habit, and no history of any addictions. No history of similar illness in the family or any other medical illness. Now coming to the examination part, so the patient was conscious oriented. BP was normal. She had tachycardia, marked tachypnea, although room air saturation was normal. Apart from that, she also had pallor. And we noted a diffuse swelling in the anterior aspect of the neck, which was mildly tender on palpation. Apart from that, she had a diffuse posterior pharyngeal edema and a decreased mouth. On systemic examination, she was found to have marked use of her accessory muscles of respiration. Air entry was decreased at the bilateral lower zones, and there was normal vesicular bed sounds, no added sounds. Her CVS examination, her abdomen examination was normal. Her musculoskeletal examination was normal. At the bilateral shoulder and hip joints, there was no restriction or pain on passive movements. She was conscious and oriented, although a detailed examination was not done at the presentation as she was in respiratory distress. So, for further evaluation of her, further evaluation was done. So now summarizing the case, so we have a 9-year-old female. She is pregnant at 12 weeks of gestation with the background history of SLE and multicentric Castleman and has been on and off steroids. Now presenting with acute onset fever and rapidly progressive shortness of breath with significant orthopnea. So with this in mind, what could be our differentials? So on one hand, I like to keep we've kept a possibility of an infective etiology like an influenza-like illness or an acute viral syndrome. Whereas on the other hand, they can be flare of an underlying autoimmune disease or maybe an overlap syndrome. So now for the evaluation, she was admitted in ward. At day 1 admission to the ward, she had marked tachypnea and that required an NIV support. Initial X-ray with abdominal shield did not show any lung infiltrates or any hilar lymphadenopathy or pleural effusion. So routine investigations were collected and she was found to have lymphocytic neutrophilic leukocytosis with transaminitis. So in view of an underlying infection, she was started on IV antibiotics. Further, bedside ultrasound was done, which showed normal lung, heart, and abdomen, and there was no fluid overload. Fetal cardiac activity was also assessed at admission, which was normal. An ultrasound neck was done in view of the swelling, which showed diffuse subcutaneous and muscular edema and no lymphadenopathy. So, gradually over the course, the patient worsened and she became lethargic and drowsy, and she had severe respiratory acidosis due to CO2 retention that required mechanical ventilation. After which the patient was shifted to ICU and she was intubated in OT because she might have required an emergency tracheostomy at that time. After which the patient was shifted to ICU. So initial workup in the ICU was, initial infective workup sent was negative. She was found to have raised inflammatory markers. Apart from that, further evaluation was done which showed elevated LDH and as we can see, there was markedly elevated CK levels that was approximately 200 times the upper normal limit. So with such markedly elevated muscle enzymes, we have kept a differential of myositis. And with such high levels of enzymes and rapidly progressive course and on the background of an underlying autoimmune disease, we have kept a diagnosis of an autoimmune more likely than an infective etiology. And on day 1 itself, the patient was started on IVIG. So after initial stabilization, done a neurological examination, which was suggested of a pure motor syndrome with proximal symmetric upper and lower limb involvement and also involvement of the neck muscles. So with this pattern of weakness, but our patient presenting with a predominant respiratory complaints, we further went to assess her power of her respiratory muscles, for which I like to call a radiology as well.
So we did a bedside ultrasound of the patient. So this is how the diaphragmatic function is assessed. We place a cadmium probe in the subcostal plane and identify the posterior superior part of the diaphragm and place an M or line. And this is how a normal diaphragmatic motion appears. During inspiration, we see a normal upward peak, which is called an excursion in a normal diaphragm. However, in our patient, if you see, instead of normal excursion, there was a negative excursion, which actually indicates a diaphragmatic dysfunction or a diaphragmatic palsy. This pattern was actually seen on both the sides. So, in addition to the negative excursion which was seen, there is also lack of inspiratory thickening of the diaphragmatic muscle, which also points toward diaphragmatic dysfunction. So, with all these findings, we gave a possibility of bilateral diaphragmatic palsy.
Thank you, sir. So now we know that our patient has proximal upper and lower limb involvement and also the involvement of the neck muscles and now a significant diaphragmatic involvement. So by day 5, as we can see over here, the muscle enzymes, they have markedly reduced, but she had persistent ventilatory requirements. So because of that, a decision was made to further start her on NPS pulse. Other workup was collected which showed an ANA positivity. ENA was positive for SSA, SSB, and anti-DSDNA was negative. She had low complement levels. So with this, we had a possibility of an overlap myositis more likely than an SLE myositis or an SLE flare. So now further, as we can see, she had persistently low neck muscle power and also high ventilatory requirements. So decision was made regarding the use of starting rituximab, but further she developed VAP during the course, which was treated with appropriate antibiotics. And because of her severity of her illness and a possible need for further immunosuppression, she was given an option for MTP. So because of prolonged mechanical ventilation, she was tracheotomized. Further, by day 18, we noted an increase in the muscle power of the neck, and she was able to tolerate a pressure support mode. So as the power was improving and some uncertainty regarding the safety in pregnancy, rituximab was currently not given. Further, she underwent an EMG, which was suggestive of a myopathic pattern, and there was also evidence of membrane instability, which was goes in favor of a inflammatory myopathy. So gradually by day 22, day 25, she had improvement in the power of her upper limb and lower limb as well, and she was, with daily SBT trials, she was able to tolerate a pressure support mode. And by day 25, she was weaned off ventilatory support and was stable and repair. Further, after stabilization, for the extent of the muscle involvement, we have done a whole body MRI. I'd like to call Surya for further discussion.
So we have a whole body MRI of 24th of August. So the first image is the whole body star coronal image, and the second image is the star core image of the thighs, and third image is the star core image of the legs. So as you can see, these are the muscles which, this is the normal appearance of muscles on star core, they appear dark. However, if you look at the muscles of thigh, which is better seen on the second image, they show diffuse hyperintensity and almost all the muscles are involved, and the involvement is also almost symmetric. And if you look at the muscles of leg also, they also show significant hyperintensity, which is more than the muscles of thigh. Again, the same can be better seen in the third image. Looking at the star coronal image of the shoulder, we see, although there is no significant hyperintensity, what we see is all the muscles appear thin and ribbon-like, which suggests significant atrophy involving, again, the involvement is almost very diffuse and symmetric. Looking at the axial image of the leg muscles, in addition to the T2 hyperintensity which we saw on the coronal images, we also see that the muscles are showing significantly reduced bulk. Summarizing the findings, so what we saw was diffuse hyperintensity involving almost all the muscles of both the legs, which was more pronounced in the lower leg muscles. In addition to that, we also saw that the muscles of shoulder girdle, pelvic girdle and legs had significant atrophy. So based on these findings, we gave a possibility of myositis of probably systemic or an inflammatory etiology.
Thank you, sir. So I'd just like to mention that we have done this MRI after an initial course of immunosuppressants. So probably that was the reason that we could not find edema, but there was significant atrophy of the involved muscles. So with all these differentials in mind, we have sent a myositis panel, which came positive for MI2 alpha, PMSL75 and SRP low 52. So with SRP positivity, we have likely diagnosis of overlap myositis, that is an immune-mediated necrotizing myopathy. Further, with daily physiotherapy, the patient, the tracheostomy tube was removed and a steroid-sparing agent was added. And gradually her muscle power improved. So we had a final diagnosis of SLE with mucocutaneous musculoskeletal manifestations currently not in play, a multicentric Castleman disease hyaline vascular type with lymph node involvement currently in remission. Now presenting with overlap myositis and immune-mediated necrotizing myopathy, which is SRP positive, and with the current gravidas status and the period of gestation of 16 weeks and 4 days at discharge. So at discharge, the patient could do all her activities of daily living by herself. And on 1 month follow-up at OPD, she was asymptomatic and had full power at all the joints. We've also had an early level 2 scan done, which was normal and did not show any gross congenital anomalies. Now I'd like to request Bharti ma'am for further review of literature.
Thank you, Dr. Racheta. So now we will just be looking at some of the literature we had reviewed during the management of this case. First of all, overlap myositis is classified as anybody who's fitting the ACR criteria for idiopathic inflammatory myositis in the setting of another connective tissue disease. Most commonly, this has been seen to occur with systemic sclerosis. Coming to SLE and idiopathic inflammatory myositis, it's seen in less than 10% of patients with SLE and usually starts within 1.5 years from the initial onset of SLE. And these patients usually only have musculoskeletal and cutaneous manifestations with low incidence of renal and CNS involvement. And they can have a wide variety of myositis-specific and associated antibody positivity. We have found one case report of anti-SRP positivity like in our patient. It can be either necrotizing myositis, dermatomyositis, or polymyositis. The treatment includes steroids and steroid-sparing agent, and most of these patients have improved with treatment. The myositis, this is one of the largest cohorts of myositis specific and associated antibodies in India. In the overlap myositis, most of the patients were antibody negative, with about 1 to 2% of the patients showing SRP or MI2 positivity. The current classification criteria for inflammatory myositis can be done with or without a muscle biopsy within the presence of an antibody and other clinical manifestations. And looking particularly into the immune-mediated necrotizing myopathy, any of the following, that is a very high creatinine kinase CK levels with proximal muscle weakness or a myopathic pattern on EMG with an antibody positivity will be enough to diagnose a patient as immune-mediated necrotizing myopathy. This SRP mediated immune-mediated necrotizing myopathy forms about 30% of the necrotizing myopathy cohort, and it is usually characterized by a very acute onset of proximal muscle weakness. And many patients can have, almost 70% of the patients can have neck muscle involvement, and about 12% of the patients can have respiratory muscle involvement as well. And one of the characteristics in histopathology is that there is patchy myonecrosis with myoregeneration and the paucity of inflammatory infiltrates. The treatment includes induction therapy with corticosteroids and IVIG. Rituximab can be considered in patients who are not improving with therapy, and a maintenance therapy with steroid-sparing agents like azathioprine, methotrexate, or AIIMS. The usual course of the patient is that after initial induction therapy, there is a rapid fall in the creatinine kinase level, and muscle recovery lags behind this rapid fall, which is what we had seen in our patient as well. And the outcome of these patients currently with the data we have is quite varied, but around 50% of the patients do have complete recovery from few months ranging to 2 to 4 years. Pregnancy and idiopathic inflammatory myositis has been studied, and there's a lot. This is most of the information which is available till now. It can occur either before the onset of pregnancy, during pregnancy, or also in the immediate postpartum period. And almost all of the patients do have musculoskeletal involvement, with about 13% of them having respiratory muscle involvement. Other than this, we can see skin involvement and Raynaud's phenomena as well. Overlap myositis forms is seen to have the lowest amount of incidence in pregnancy, with dermatomyositis having a more incidence. Coming to a case, just discussing a case series in which there were pregnant women from the second and third trimester who did present with with respiratory failure. Here they were treated with corticosteroids and IVIG, and most of them did have a good recovery. Apart from this, a wide variety of, again, myositis specific and myositis associated antibodies have been seen, with one case report again of SRP positive necrotizing immune myopathy in a pregnant patient. Again, steroids are the first line along with IVIG, and you can use steroid sparing agents like azathioprine and hydroxychloroquine for further management. Coming to the pregnancy outcomes, more than 50% of these patients do have a normal delivery. And the risk factors for a poor fetal outcome include either a delay in commencing treatment, a very high CK level at the diagnosis of during the first initial presentation, or poor response to corticosteroids, or pregnancy during an active disease. The immunosuppressants in pregnancy currently, the ones which are most compatible are the ones which have the most amount of data and have been used from a long period of time, which includes azathioprine, steroids, IVIG, and HCQ. The role of rituximab is still conflicting, and it is still there's still insufficient data on its fetal safety. The last thing in our patient was that she was diagnosed with multicentric Castleman disease as well during her previous course of illness. This is usually a disease which is caused by hypercytokinemia, which leads to a polyclonal lymphoproliferation. And the first line therapy is usually a IL-6 directed therapy, with rituximab steroids as second line therapy. And most of these patients usually have a relapsing and remitting course with a 5-year survival around more than 50%. And with steroids, they can have some temporary relief, but there is a higher risk of relapse. And in a setting of an underlying autoimmune disease, there is a gray area where some SLE patients with lymph nodes may have a Castleman-like histopathology or Castleman-like histopathology. And some patients with SLE lymphadenopathy do have some amount of response to steroids. On the other side, even in Castleman disease as well, we can see ANA positivity. Apart from this, there is, in literature, there are multiple cases reported of SLE along with multicentric Castleman disease, and most of these patients have had mainly lymph node involvement, which can either be unicentric or multiple lymph node involvement. They have been treated mostly with the previous recommended therapy, that is with almost high-dose chemotherapy, with a few patients being treated only with steroids. So coming to our take-home messages from this case and review of literature, Pregnancy can affect the course of many autoimmune diseases, there can be exacerbations or new manifestations. There can be favorable outcome of pregnancy can be seen in idiopathic inflammatory myositis with prompt management. And myositis can present with early and severe respiratory muscle involvement, as we had seen in our patient. With the recent availability of the myositis panel, the diagnosis of idiopathic inflammatory myositis has become easier. Response to treatment of myositis can take a few weeks to few months after initiation of appropriate immunosuppressive therapy, and a multidisciplinary team approach is of utmost importance in the management of these patients. Thank you.
Very so. I would just want to say that this successful management of these patients highlights two important things. One is when we're dealing with muscle inflammation or myositis, pure myositis, time is muscle. If you see, as far as this patient is concerned, explosive presentation, but we had managed to start her on anti-IgE5. And if you go by the literature and the outcomes of immune-mediated myositis, they have been fairly poor, but in our case, because of the expeditious management of IPIG, followed by timely discovery, made the patient improve in such a way that she was functionally much better and obviated the need for secondary immunosuppression like vaccine or a combination of these agents, which may be required in a subset of these patients. And as we can see in the MRI, right, despite such aggressive management, we still had fibrotic changes. So the message is identify them early, treat them early aggressively, and we can get good outcomes. And regarding management of pregnancy in these patients, it is dynamic. Whether to terminate, whether to continue, it was shared decision, not just with the patient and treating team, but all the departments. I'd like to congratulate.
So, this the long-term implication of this condition.
It depends upon the response, initial response, which in this case is very good. We covered quite fast, she was excluded, and followed quite well. So it should be fine. The main thing that this patient came to us was around 12 years back. SLE, no major organ involvement. A few steroid and procedures. She was doing fine, wanted to go over. A couple of years later, she was very big biopsy was eczema disease. And around that time, she entered the nursing college. Now she is a nursing faculty. So her follow-up has been very regular. After the eczema disease, for which we insisted that we need to treat because of the lymph nodes recurring, but somehow she didn't follow. So that's why there is a gray line, gray zone, SLE, developing multicellular eczema, part of the immune process only. What is surprising is 10, 12 years later, a relatively mild disease one, no major organ involvement, she suddenly presented for beauty. Which is fever and respiratory. And so more than 88 the onset of the SLE disease, now she comes up with a newer overall manifestations. That was the interesting part, and expeditious management really that's what this case here. So any comments?
Right. So very interesting case. So going forward, I mean, this patient had muscle weakness, which led to the patients running up to the category. So very quickly was shown that the patient having that. So are the earliest signs of muscle weakness or of patient related extremity or a you are inspired for with the patient then suggest In this case, X-rays were normal. X-rays were some normality, and so in that case, I just wondering if we had done a bit suspect that the patient is having this, or we could have some other this is not correct.
Initially, like on day one itself. Sir, on day one itself, when she had so much of respiratory this thing involvement, with like a focus which was not showing any shreds, no lymph nodes. X-ray was also done. This is no lymph nodes, no effusion as well. Then further, we had a very high suspicion of a myositis itself. After which we had raised enzymes. So further, that was not done initially. We further followed up with an ultrasound.
This to be time on day one, we were restricted billion proper infections was that was this day one.
Yes, very nice since very clear about that she had lots of patients figures. And now one of the indications for us is if a patient is fully compliant, then we go to like 9 months. There can be regular for 9 months instead.
Thank you, sir.
So we are not popular among the physicians, and then also with the business family. But we have to do this topic. It is true, we replace it. Children.
Good afternoon all. Myself Dr. Jayvan George. I'm a senior resident in the Department of Orthopedics. Good afternoon everyone, welcome to our CCR. We are presenting avoiding knee replacement no more. So as you all know, osteoarthritis of knee is a very prevalent condition. The prevalence has been increasing over the past few years. Basically, females are more affected than males, and currently about 50 million people in India are affected with osteoarthritis of knee. So if we know that prevalence is high, so let's look at why it's high. So this was a study which was done in healthy knees, Indian knees. So they looked at 1,000 Indian knees, and they found that majority of them have a constitutional varus. So if you look at the right side, you see that this is our normal knee supposed to look in neutral stance. That means there's a weight-bearing axis which passes from the hip joint with angle. It passes through a straight line through the mid of the joint. In varus knee, there's an angulation there. So in Indians, we found that we have a higher degree of varus compared to the Western population. So again, looking at biomechanics of the knee. So what happens if we have a varus knee? So here we see that the red line, this is the weight-bearing line. This is actually passing medial to the center of the joint line. So when the mechanical axis is not in center, there is an uneven load distribution, and that leads to wear and tear of the affected compartment. So as you can see here, if a patient is having a varus knee, like most of the people in India has, there is a higher loading in the medial side that predisposes to a medial osteoarthritis. And studies have found that if we have a varus alignment, there's a 4 times increased risk of medial progression of OA. So in short, it means that people with varus knee, especially the Indian population, we are at higher risk of medial osteoarthritis. Now look at the stages of an OA knee. So we see on the leftmost side, this is like a normal knee. So you can see there's a good space, the white space, there's the cartilage thickness. So this is the normal knee. As we age, we see that there's initially, as we saw before, since we have a varus predisposition, so we tend to get a medial osteoarthritis, and it even progresses further to a global osteoarthritis where both the knees are affected, or both the compartments of the knees are affected. So the real question is, how do we treat that? First of all, obviously, we try conservative measures, and if they don't fail, then that's where our role comes as orthopedic surgeons. We have to do some surgery to help them from the suffering pain. Now the question is, do we treat them both the same way? So first of all, like obviously, these are the three, like the good, bad, and ugly knees, right? So the bad knees, these are the ones in which there's always a dilemma. I mean, these are bad, but not that ugly that they need a knee replacement, right? Like some part of the knee is still preserved. So doing a complete total knee replacement might be too much for this patient. Or, I mean, do we still wait this patient to become this stage so that we need a knee replacement? I mean, that will be making the patient to suffer a lot that, we are not doing the appropriate management. So that's where our role comes in terms of osteotomies, which are knee preserving surgeries. So these are the patients who are ideal candidates to preserve their knee joints. So they might be relatively young patients who might have just isolated medial compartment osteoarthritis, might be a suitable candidate for knee preservation surgery like tibial osteotomy, and people who might be relatively old in the later stages of osteoarthritis involving both the compartments might be a suitable candidate for a total knee replacement. Unfortunately, what we see in the literature and what we see in our general practice is that, as we know, like majority of the patients just have osteoarthritis in one compartment. Unfortunately, like most of the patients undergo TCAR just for osteoarthritis in one compartment. Even within the patients having one compartment, we see that medial osteoarthritis is the most common. But most of the patients undergoing TCAR in this country are undergoing TCAR for just one single compartment. And just because of that, we see that the rates of TCAR has been on the rise, especially in the younger patients. So you see on the right side, you see that the green proportion. So obviously the number of TCAR is rising. Not only that, the patients undergoing the TCAR are more relatively younger and younger patients. That means that patients at a much lesser severity of osteoarthritis are undergoing a total knee replacement. So this is the question. We all might be familiar with this, right? I mean, we have a bad phone or a bad laptop. When we take them to the shop, they're not bothered of repairing it. They instead want to just replace it. That's the easy way, right? But is that the right thing to do? I mean, just because we have a bad knee, does that mean that we have to just replace them? So what do you do what if you are doing like a TCAR for a patient like this, right? So you can see here, as we described before, relatively normal lateral compartment. And you see an isolated medial osteoarthritis. And unfortunately, this is how most of the patients present to us. And these are the most of the patients who are undergoing TCAR currently in this country. And if you do TCAR in these patients, and this would definitely be an overkill. It will be like burning the whole house to kill a spider. Right? And these patients, when they are relatively young, there's a higher risk that they undergo revision at a later stages. And obviously, doing a knee replacement for such young patients might affect their lifestyle activities and can cause physical restrictions. As you know, in India, like most of the patients want to have a life where they want to like sit cross-legged or use Indian toilets where they want to deep squat. So if you're doing knee replacement in such patients, that affect their quality of life. And not only that, when you do TCAR at young patients, studies have shown that there's higher risk of failure. So the green the green lines in the survival curves show that when patients were done TCAR when the age was less than 55 years, they had the highest failure rates. Probably because that these patients have a higher demand, suggesting that when you do TCAR at younger age group, they have a higher risk of failure. And what happens when you do like inappropriate case selections for TCAR? Like when we are trying to skip steps, when we are not doing the appropriate treatment, we see that when TCAR is not done for the appropriate conditions, patients does not have an improvement in the short term. Not only that, they have substantially lower improvement in the long term when compared to patients who have done TCAR for the right reasons. So there comes the role of something called the knee preservation surgery, of which we are going to talk about the high tibial osteotomy today. As the name suggests, it's a osteotomy, which is a bone cut made in the tibia at a level higher than the tibial tuberosity. As you can see here, this is a normal knee in which having a osteoarthritis of the medial compartment. The black line is the mechanical axis or the weight bearing axis. We see that the weight bearing axis is medial to the center of the joint. So our goal is just simple. We just make a cut in the bone, open it up so that the weight bearing axis shift laterally towards the center. And studies have shown that just shifting it not to center is not enough. We might have to shift a little more. Technically a point called the Fujisawa point is slightly lateral to the midline, so that there is more load distribution on the lateral compartment, and there will be unloading of the medial, which can lead to relief in the pain of the patients. So looking at the goals, obviously the first and foremost goal is correct alignment, which results in a decreased pain for the patients and improves the outcome. And ultimately, we are aiming at delaying or avoiding the need of total knee replacement in these patients. These are the indications. It might look a lot like a lot of criteria there, but if you look at that, all these criteria, most of the patients undergoing TCARE are also come under this criteria. That means most of the patients undergoing TCARE in this country currently, they can be included in this criteria, like isolated medial compartment arthritis, age 40 to 60 years, a BMI of less than 30, high demand individuals who have intact ligaments, a varus deformity less than 20, flexion deformity less than 15, or range of motion more than 90 degrees. A functional demand, sir. So it's a more subjective term, but it means like functional demand in terms of lifestyle demands for the patients. These are some candidates which are not good for the HTO. For example, patients who have inflammatory arthritis, some patients will have a high flexion deformity, or patients who have a global or tri-compartment arthritis. So I would like to invite Dr. Vijay D to continue with the surgical techniques.
Once we know the stage of the disease and we prepare the patient for the surgery where we can preserve the knee. So apart from pre-anesthetic checkup and preoperative planning, we need these special instruments to perform this surgery. This is the video demonstration of the same technique where initially we place a K-wire in a desired position of the osteotomy, and this osteotomy is performed in a 2 planes, and these K-wire which are placed are act as a guide wire over which we using a thin saw blade we do a osteotomy in a sagittal plane. Then we do an oblique osteotomy parallel to the tibial tuberosity in another plane. So basically it's a biplanar osteotomy. Caution has to be taken while doing this osteotomy is to not to injure the patellar tendon or not to fracture the tibial tuberosity. So once we make a osteotomy, we introduce this special instrument in the osteotomy, which is which opens up in a graded manner. We need to open this osteotomy when we get a desired mechanical alignment is achieved. Once we achieve the desired mechanical alignment where it is supposed to be, we stop it there and we see under the image that from the center of the hip to the center of the ankle where it is supposed to pass just lateral to the midpoint of the knee joint. Once we achieve the desired alignment, we use this special locking plate, and we maintain the osteotomy site using a laminar spreader which is just beneath the plate, and we fix with the locking screws. So this is our own case which the same steps are replicated. We initially put a K-wire in a desired position of the osteotomy, then we perform a biplanar osteotomy and we open up till we achieve a desired mechanical alignment of the lower limb. And once we achieve that alignment, we use this special plate and we fix in the to maintain this osteotomy. And one has to be very cautious before fixing all the screws that the alignment should be in a perfect position. This is the final intraoperative picture of the same patient where we have achieved the desired mechanical alignment. And the same patient who is very satisfied came for the other knee osteotomy, and which we have done 4 years ago. And long-term studies of this osteotomy have suggested that more than 90% of the knees of native knees can be preserved beyond 15 years after performing this osteotomy, and only 10% of the patient which needed to be converted into TKR, that too after a minimum follow-up of 12 to 14 years after performing this osteotomy. And one of the reasons for excellent outcome that there is a good biological condition within the knee is seen by the researchers across the globe in terms of regeneration of the cartilage. When we make a favorable mechanical atmosphere within the knee joint, there is a cartilage regeneration in the knee and the middle compartment, which is one of the reasons for the good excellent outcome. But why it is not so popular? Just because of lack of awareness among the surgeons, which they fail to give an option to the patients. It is also because of lack of exposure of the surgeon, and they fail to acquire these skills during their training period, and glamour of orthoplasty can also contribute at some extent. Now I request Professor Rohit sir to throw a more light upon this technique.
So knee replacement still holds a significant role in the management of osteoarthritis. So who is best suited for knee replacement? So these are elderly people more than 60 to 65 years old, where they have a bi-compartment or tri-compartment disease and all non-operative measures have failed. For these people, TKR is the best option. So if somebody is not best suited for TKR, now these are the people who are less than 60 to 65 years old, only medial compartment has affected and non-operative methods have failed. Obviously these people need some surgeries, but they are not suitable for TKR. So for these people you have the option of high tibial osteotomy as described before. So high tibial osteotomy gives good pain relief. There is no restriction of activities or no need to change the lifestyle. It's much cheaper and more suited for Indian conditions where people need to sit cross-legged or squat. So is HTO a new procedure? No, it's an old procedure. It is even older than the knee replacement. So is it an abandoned procedure? The answer is no. It's the Walmart-like approach of the physicians and the surgeons. Now, what is this Walmart-like approach? Now, if you look at the supermarket, the commodities which have to be sold on priority, they are displayed in the passage where the people walk and at eye level. And whereas the rest of the commodities which are not to be sold in priority, they are in the far end of the supermarket, far above or below the eye level. So the Walmart approach about this procedure is that the option of this surgery is not offered to the patient. Nobody offers them this, so the patient also doesn't know about it. Then why are we talking about it? Because we like to re-emphasize that TKR is not suitable for everybody. HTO is a very good option in medial compartment osteoarthritis, and with the newer techniques of HTO, the results are consistent and good. The goals for HTO in varus deformity is to shift the weight bearing from medial to the lateral compartment to a point which is around 60 to 66% of the tibial width, and this is called the Fujisawa point, as has been described before. So this is the same thing that you make a cut in the proximal tibia, open it, and this produces a valgus in the limb, and you can titrate the opening of the gap by looking at the mechanical axis by placing a long rod or a metal wire. So the titration is a thing which you can fine adjust your angle, final angle. Now to give you an example, this is a 50-year-old lady who is a OPG doctor, has a bilateral medial compartment arthritis. When the HTO was offered to her, she was very reluctant because she never heard that procedure and everybody was talking something else. So she underwent HTO on the left side as a trial, but came back for the right side when she was happy. And this is the pre-op and the post-op mechanical axis, and you see that there is a change in the mechanical axis. This is a 45-year-old lady who had a limited walking because of medial compartment osteoarthritis. she had a ipsilateral shaft femur fracture, and we did a HTO in this case and shifted the mechanical axis, and she had relief in the pain, which is more than 10 years now. This is a 52-year-old lady. She was unable to walk even half a kilometer. All medical treatment had failed, and in this case, she wanted a bilateral surgery at the same sitting. We did it, and she's quite happy with it. Now, this is a surgery which was performed in a patient who is 65-year-old. 65-year-old. He's a national level hockey player. Conservative treatment had failed. Wanted to preserve his knee, and this is the recently operated patient, but he's quite happy with this result. Now, all these cases that I showed you were primary osteoarthritis. You can have secondary osteoarthritis also in the knee, and HTO is successful in this situation also. Now, this is a 36-year-old lady who had a road traffic accident. She had a varus deformity because of malunion in the proximal tibia on the left side. She had pain on the medial side of the knee, and we did a HTO on this side, and she could walk pain-free after this surgery. Now, if you look at the top left figure, this is a undisplaced fracture of the proximal tibia, which was treated in plaster, but somehow it malunited in varus and recurvatum. And if you look at the standing X-ray, there is increased space on the medial side. Now, you can have increased space only in situations either way you have the ligament laxity or you have a depressed fragment. So we did a HTO for this patient, correct, both his recurvatum and varus, and he could walk pain-free and in a stable knee. This is again a post-traumatic varus and recurvatum in a 30-year-old lady who had a road traffic accident. She had difficulty in weight bearing, and again we corrected the varus and recurvatum in this case, and she could walk comfortably after this. This is again a post-traumatic varus and recurvatum, grotesque shape of the proximal tibia. High tibial osteotomy took care of everything, and he could walk comfortably. Now, people who undergo surgery in proximal tibia can also have varus deformity and medial osteoarthritis. This is a 21-year-old male who had a giant cell tumor in the proximal tibia, underwent curettage and bone grafting. Everything healed well, no recurrence of the tumor, but he had a varus in the proximal tibia. He is a barber by profession, couldn't stand for a long time, and it affected his profession, his earning. So we did a proximal osteotomy here, fix it with a fixator, and achieve this alignment from this to this. This is the healing after that, and he could go back to his profession when he had no pain. This is a 31-year-old male, again a giant cell tumor of the proximal tibia, underwent curettage and bone grafting. Now, there was no recurrence of the tumor, but you see the grotesque shape of the proximal tibia, and he had medial knee pain. He happens to be a medical representative in a pharmaceutical company outside Delhi, but he came back because nobody was ready to touch him. He's too young for knee replacement, and you can see the mechanical axis is not even within the knee, it is outside the knee. So we just did a correction of his axis, mechanical axis, and this is the alignment that we got. So this is the patient. Now if you see his limbs, you cannot make out from a distance which knee was operated. Except for the scars, when you see from the front, you know this is the operated knee. Otherwise, when you're looking from back, both the limbs look almost the same. You can walk without the limp, without pain. Now, there are many frequently asked questions regarding this procedure, both by common person and also doctors, physicians, and even orthopedic surgeons. Now, will it cause lateral compartment osteoarthritis because you are shifting the mechanical axis laterally? Obviously, answer is no. It took 50 years to develop medial compartment osteoarthritis. It will take another 50 years on the lateral compartment. By the time the patient would have lived his full life. Is this procedure good for complete cartilage loss on the medial side? The answer is yes. If you do, the patient is without pain and even cartilage regenerates on the medial compartment. These are the pictures from the studies which are published. People say this is a stopgap arrangement. Oh, it will fail after a few weeks or few months. Why do the surgery? बाद में यार knee replacement ही करा लेना. So strictly speaking, it is a stopgap arrangement, yes. But this time gap is long when this surgery is done accurately. No overcorrection, no undercorrection of the alignment. Then the results are good and they're long enough to avoid a knee replacement in the patient's lifetime. And strictly speaking, even knee replacement is a stopgap arrangement. Nobody said that it can last forever. Is it backed by long-term studies? Yes. If you see the Pochino, whose picture I showed you, the cartilage regeneration, he shares 97% survival at 7 years, 95 at 10, around 87 at 15 years. 97 at 10 years, 90 at 15 years, 94 at 5, 80 at 10. That's a pretty long survival of these procedures. And if you look at all the high table osteotomy performed by different methods, the overall survival is around 99 at 5 years, 94, 95 at 10 years, and around 85 at 15 years, which is a pretty good survival rate. Does it compromise future knee replacement? The answer is no. There is no difference between primary TKR and a TKR which is performed after the HTO. Multiple reports are there in literature. On the contrary, your surgery becomes easier when you don't have to correct the deformity. Is bilateral procedure possible? Yes, it is possible, but you need more blood transfusion. Can it cause patellofemoral problems? The answer is no. There is no issue regarding patellofemoral osteoarthritis. Some people say it's not possible in the old age, but today the age of the patient has not a factor to be considered. Classically, it was up till 60 years, but now that factor is not there. Multiple reports are there. This is in 2017. The results showed that the age did not influence the clinical and the radiological outcome depending on the age. And the two groups were more than 65 and less than 65. The result was similar in both the groups. Another study, 2019, there was no significant difference in the survival of HTO between the two groups divided by the age, less than 64 and more than 65. And one major issue regarding this procedure is that it's unpredictable. You don't know whether the patient will benefit or not. The answer is big no, but if you want to be sure before surgery, you can give him a temporary unloading brace to be worn externally. And if the patient is happy with it, obviously the patient will be happy after HTO. If you don't want to give a brace, give him a lateral heel wedge. That's almost doing the same, creating a valgus at the knee joint. And if the patient is happy, he will be happy after the HTO. So to conclude, HTO is a rational, logical and time-tested technique. It's not a new technique that I'm talking about. You have good long-term results now published in the literature. It allows unrestricted activities, more suitable for the Indian population who need to squat and sit cross-legged. But you need to select your patients carefully, follow the technique and needs position. If you have over or under correction of the deformity, the results are bad. It does not burn bridges. You can still do TKR if there is a failure of this procedure. And the benefit of HTO is due to mechanical and biological reasons. Thank you very much. We'll be happy to answer any questions if there are any.
So you said a lot of Indians have constitutional leaders. So, I mean, let's see. So, that is so, and that is predisposing to the development of osteoarthritis. I'm guessing a lot of us would be also saying, oh, would also be having the same problem. What can be done to offset the progression? Can something be done short of ACS?
The only thing that you have in your hand is to avoid being overweight. Sorry? That, you-
See, a lot of studies have for extreme. That's because they are very high scholarship. That is the reason why most. That's how you build the common sense. That's what he's trying to do. He's building a common sense. Common sense is what teacher. As against something which is very low. This common sense, build up of the common sense is what we do. And that's what the government.
See, another reason that he has not, it's a very good point that is picked up, that all my references are mostly from non-English speaking countries.
That's very specific geographical bias. If you think teacher has been sold to you by
So I never pointed out in my talk, but he's picked it up. If you see, they are mainly from Japan, Korea, Middle and Europe. One reason is they have a longer lifetime. Another reason, all the patents of knee replacement are with the English speaking countries. So Japan doesn't have patents for no big company from Japan. So the government of that place also is very restricted about the procedure that can be done. Nobody can do left, right and center. There are many processes that are not approved in Japan in shoulder. So they have come out with different procedures. So it's the money game which plays. It's the government rules that plays. It's the thought process that you have.
So what is it after TKR we usually say that the patients start walking with these without any assistive devices. But it's normal course after HQ.
So you said patient starts walking unassisted immediately after knee replacement. That's what you want to say? No, first of all, that statement is not true. It takes around, say, how much would you say he is the knee replacement surgeon? It takes some time. It takes 2 to 3 weeks to be off without walker, do good exercise, and at the same time. But even if there is a plus minus of 1 or 2 weeks, does it really matter? Does it matter? What are you going to do in 1 week if there's a difference of 1 or 2 weeks? Okay, statistically or graphically, if you show in the graph, that will make a big bar and a small bar. But does it matter in a patient's life? Just think about it. There are studies, I have not quoted. At times, people have shown return to work, return to sports is much earlier with HTO because you have a natural knee. Proprioception is there. Proprioception, you remove everything, all the ligaments you remove, which are inside the knee joint, you just keep the collaterals. You remove the cruciates. So proprioception, you are taking out. Some knee replacements keep the PCL, but you always remove the ACL. But
Thank you very much. I think this is an illustration of the situation in real life. Many times we think that our decisions are led or informed by evidence, but I think we discount the role that the medical device on the decisions we take. So, though your presentation and science seems to be good, it's not going to be an easy battle because what is arrayed against you is greed, and that is much more powerful than it is the truth. I'm not saying that HCO is not good. I'm saying that you have to make a huge effort to get the
in the journal Arthroscopy, August 2022, it will be published regarding a book called Hypocrisy. It was written by orthopedic surgeon and a dermatologist. The dermatologist named this Barbara. They are from Australia. And hypocrisy, they have read the word from the hypocrites. English word. And what they say is, don't treat what is normal. Don't medicate, overtreat what is just normal. And this was written by Randall. He sent publication to a dermatologist. And it happened to be a procedure which is a very shoulder. This dermatologist said this should be not to be done, has no value, and this is of surveillance. He has published so much on this procedure, and this is not only the procedure, it's that's not the procedure. She gave the book to him, and then he read it, and he found that most of the procedures that we say, अच्छा है, वो भी अच्छा है, वो भी अच्छा है, nothing. It's not good. So that's the evidence that we generate. The dermatologist to generate that evidence, different perspective. And orthopedic surgeon with the orthopedic surgeon, publish that. So you can, if you Google what hypocrisy work, you can find out. Google it.